Hi guys, this is Yanis with IK Endodontics. So this channel is being made so we can share all the tips and tricks for root canal treatments. Okay, so today we're going to be discussing about LR7. Diagnosis was asymptomatic irreversible pulpitis with symptomatic apical periodontitis. As you can see here, we do have a periapical radiolucency and a big carious lesion that goes into the pulp chamber. All right, so first thing we're gonna do is rubber dam. It's been around for so many years. We ought to use it. Okay, you want to seal the tooth out very nicely. Now, if you do got any leaking margins like I do have in this case over here, you can use liquid rubber dam like I'm using now, and you want to seal everything out nicely. Because if you don't do it now, it's going to be really frustrating getting all that saliva in. Plus, you will be reinfecting whatever good work you're doing, which will reduce the prognosis significantly. Okay, so what we're gonna do next, what I did was I did a quick pre-endo build up just before I start recording. What I used was Teflon tape in the middle, like you can see here, that tape. It's very easy to put, very easy to remove. It's a quick tip that I learned, and it just allows me not to block my canals when I'm doing the pre-endo build up. Okay, because you will have to remove all the decay first, and then if the pulp chamber is exposed, you're going to be struggling not to put any composite or filling material in the pulp chamber. Thus, by putting this in, you're saving yourself a lot of time. And as you can see here, I will be fast forwarding this. You can very easily remove it afterwards just by pulling it out. There we go. So we got our pulp chamber exposed. So very easy now. We're going to be using a non-cutting tip burr. In this case, I am using the Endo Z burr, but you can use any brands, any type you like. Just make sure the tip is a non-cutting one. So you put it in. You want to create a straight line access. You don't want to be over preparing the tooth, because the more tooth you remove, the more prone will be to fracture, but you want to remove enough so you do have a good straight line access and you make yourself and your job much easier. So in this case, after my first go, I take a look and I don't like this side. We do have a little bit of rough and regular denting here, convex part here that I want to be removing, and I'm going to be smoothing the rest out. So I go back in and I spend time on my access cavity. You guys have no idea how important it is to spend time. 15-20 minutes spend time on your access cavity, you'll be saving yourself a lot of time later on. Okay, so as you can see here, I'm going in that part that I didn't like, which is smoothing it out, just very gently and minimally. Okay, so I like what I see. Everything is smooth and nice. So this is a good access cavity. Next step, what I'll do is I'll scout the canals, plus I'll enlarge the orifices. So how I'm doing this, I'm not going to be using an orifice opener. I usually use one of my rotary instruments that I use in my normal sequence. In this case, I'm going in with an F1 Pro Taper Gold. I have found that F1 Pro Taper Gold rotary instruments, they can be used even as a single file, like a single file technique. I found them to be very resilient, but you need to be very careful, and you need to know what you're doing and be very cautious, because they can very easily fracture as well. So I'm going in. I usually go in when I'm scouting the canals. I do go in up to around 16 millimeters, so just before the markings, and this is a good way to tell whether a canal is narrow, wide, what you need to do. Like, just get an idea of what's going on. You never push the file down, because you might be creating a ledge that is going to take you a long time to bypass afterwards. So just don't do it to yourself. Okay, so irrigate, very important. As you can see here, we do have 1, 2, 3 canals. Distal one is bleeding, inflamed probably. A good access cavity all the walls are smooth, and we do have a good view of what we're doing. Okay, so I'm gonna go back in with my F1 now. I'm gonna be going into the mesiolingual one now. Sometimes it is a bit of a nightmare to get the file in. You have to pre-bend it a bit, but choose to struggle a bit more rather than remove too much of the tooth structure just to get an easy access, because you'll see that a lot of teeth tend to fracture. Okay, if you're over preparing the access cavity and you're removing a lot of tooth structure, try and be as minimal as possible. So I'm just scouting again. I'm just going up to 60 millimeters, like I said. I'm opening the orifice. I'm just brushing the walls. I'm not doing anything too specific, just scouting and going in there, just enlarging a bit the canals. I'm gonna do the same thing to the mesiobuccal one. You will see I'm just having a bit of a struggle here just to get that file in, and I need to pre-bend it and then go in again, just trying to find my way in. There we go, we're in. So I'm just going to activate it, go in, and then just brush, just open that orifice up as much as I can. Well, be cautious. Okay, so I'm just gonna do this, and then I'm just gonna using a little bit of ultrasonics now. Do use this because in the beginning and when you're enlarging the orifices, there are big chunks that get lodged in your canals and they might block it. So you want them removed. So I'm going to be using this, but I'm going to be putting hypochlorite again into the pulp chamber just to have that disinfection working again. So there we go, 3 canals. Now a quick thing, we're going to be searching for other canals later on, but we do have a distal canal that is centrally positioned between the 2 mesial ones. So that gives us a hint that most likely we do have only one distal canal. It's a good thing to know that when you're looking for more canals. Okay, so to that, I'm just gonna be measuring the working length. I want to get working length. So in this case, what happened was I could get length on the mesial canals, but I couldn't get length on the distal canal. I felt that there was a sort of ledge without even doing anything. Okay, I wasn't the one that caused the ledge. Just sometimes the distal canals do tend to curve a little bit apically, just creating that illusion. You just have to bypass that and make sure you work yourself to a good patency, okay, just before you do anything. So in this case, I do get my working length on the mesial, so I'm just gonna fast forward this so I don't bore you. We do get our length in the mesial, so I'm just trying to work my length, find my length on the distal one, but I can't get any, but it doesn't matter at this point. I keep in mind that that apical curvature might be there, so I don't worry. And what I do get is estimated working length. So estimated working length is the length that I'm allowed to work in safely. Okay, so you use that and you enlarge your canals and you make room for you to just work yourself through to bypass the ledge later on. So you just want to enlarge the apical part. See, I'm just trying to get my length. I can't get it, but it doesn't matter. See, we have a distal bleeding canal, inflamed. So I'm going to be moving to the S2 now from the Pro Taper Gold. Like I said, I'm doing a crown down, so I'm going to go on to the mesiolingual one, which I didn't manage to get length. On the mesiobuccal, I did manage to get length with the F1, so I'm happy with that. I'm going to go with the S2 now. I'm slowly brushing the canals, just brushing the canals. You don't want to put in a lot of pressure. I'm just trying to get a good angle here, and then we got length. I'm not afraid to go a few times length with this one. I'm just going to make a little bit more space for my F1 to follow. So I'm just gonna irrigate, just make sure I don't have any good amount of irrigant. I'm gonna go back into the mesiolingual one with my F1, and this time I'm gonna get length, as you can see now. So what you're looking for when you're cleaning the canals is you want your instrument to be cleaning apically. So if you see the debris now, the apical part of the flutes of the F1, you know that you've cleaned apically, and that tells you that you're okay to stop at this instrument if you want to. Of course, the literature will say that you need to go a little bit higher than that, but my thinking is that we do want to prepare minimally rather than overextend. Okay, as long as you can get your irrigant apically and your sonic, ultrasonic, or any activation that you do apically, then you're okay to do minimal invasive mechanical cleaning. So I'm going to stop at the F1 now, so I'm happy. And what I'm going to do now is I'm going to attempt to prepare the distal one. So like I said, couldn't get length. There is like a ledge, so I'm just going to try and get my working length again. I'm not able to do so. So what I'm going to do is I'm going to pre-bend my, let me just see if I can get that. I'm going to pre-bend, where is it? There we go. I'm going to pre-bend my instrument, okay? You can see here. And I'm going to go in and try and bypass that ledge or get into the curvature. So I'm going to work it down. And then the moment I do have it, I don't remove it, okay? The moment you do have it, you don't remove it. You just leave it there, okay? I confirm I got length, and that's good. You leave it there, and then you work the instrument up and down by 1 millimeter, okay? Up and down, up and down, up and down until you get your patency and you feel that it's very, very loose in the canal. In my case, I do have for my NSK Endomate, which I'm currently using, that can facilitate hand instruments. So I'm going to be using this and I'm going to be attaching it in to the mouth. So I'm not going to removing. You'll see I'm just going to bring my Endomate with reciprocating head into the mouth, and I'm going to be attaching it as it is there. There you go. You'll see me doing like now. I'm just going to be putting it in there, and then I'll let it play in real time. I'm not going to remove it. I'm just going to go up and down while activating my reciprocating. There we go. Just up and down a few millimeters, just like that, until I feel that it's completely loose. Okay. And then I know that I do have a good patency there, and I will be able to just put my F1 afterwards and get to length just fine. So I'm going to be doing this. You see, I'm just leaving it play in real life, so in real time, so you can see how long it takes me, more or less. So I'm going to be irrigating, and then I'm going to go in with my F1, let it play, and then you'll see that it just goes to length. Just like that, slides to length, and I'm happy with that. Okay, so irrigate again, and then we're good to just start searching for the extra canals. This is what I do. I don't tire myself searching for extra canals in the beginning. I do tend to clean everything that I find straight away. This gives you a little bit of confidence as well, okay? Takes a little bit of that stress away. You say that I've prepared some of the canals. I'm okay to just search for more now. Okay, and in these happy cases where you don't have any more, then you just finish the preparation. You go straight to the chemical cleaning. So I'm just gonna zoom in right here now, and what I want to do is I'm gonna search for mid-mesial. So we've said that with the distal one, it's located centrally. I do tend to brush a little bit with an Ellenberg lingually buccally, if I to see whether we do have whether we got just one orifice, and then that it might split into more than one canal. In this case we don't, so I'm just going to be searching here for the mid-mesial one. Now excuse the focus, it might be a bit off because sometimes my camera and my microscope, they don't go along with the focus. But as you can see, I will put the Ellenberg in, and I will just slowly start brushing between the canals. just like that. Okay, I'm just gonna move it forward like that. I'm just brushing, brushing, brushing. You don't want to go more than 1-2 millimeters. You don't want to be causing any perforations. You have to be very, very careful because you want to be doing good and not bad. All right. So I'm irrigating. I will be using the ultrasonics again because I have a lot of debris that I needed to remove. So I'm just gonna go. Okay, I'm just gonna go in like this. And then I'm gonna be searching for, I'm just gonna go see if I can get a clear image, just like that. I'm gonna zoom in for you guys. I know that the focus is a little bit off, but I didn't see any canals and I didn't find canals. So what I'm doing here is I'm trying to see whether the canal is close to any of the other buccal canals. Fix that for you guys. Okay, so I don't see anything here. We do 1-2 canals, nothing in between. Okay, so that means that we're good to continue with the obturation. Okay, so I'm gonna be placing my GPs in just like that, and we're gonna be taking a cone fit radiograph. Very, very important. The cone fit. I do tend to take sometimes a cone shift if I'm not very, very sure of my working length and everything. But in this case, my apex locator readings were accurate. Okay, so I do tend to trust my apex locator a lot, and I didn't take one. So I'm gonna continue by removing the GP. So what I do is I do remove the GPs. I put them in hypochlorite while I'm working where I'm doing my final irrigation protocol. In this case, I didn't. What I didn't like was the tack back of the of one of the canals immediately. So I went back in and I prepared it just to length, just to get a little bit better tack back. Okay, just did this. There we go. All right, then irrigation, and then I'm going in with my sonic activation. Okay, I do tend to use ultrasonic activation as well. It's just in those cases that I cannot get close to length with my sonic activation, but I do tend to like sonic activation as well. Okay. So drying the canals, quick tip here. When you do use your final, when you do your final irrigation with side vented needle, and when you finish on your last irrigant, whatever you're using, just go to length as far down as you can, close to length, of course, and then you just aspirate all the irrigant out. You will find that after that, you just need 1 or 2 paper points, and your canals are dry. Okay, just a quick tick. So I'm going to be drying 1, 2, 3 canals, and then I'm going to be applying a little bit of sealer with my with a paper point. I found that this creates a good lubricates, not lubricates. It creates puts some sealant on the canals. Okay, put some sealant because sometimes you'll find that when you go in like this with the paper point and just a little bit of sealant at the end, some areas do tend to miss a bit of sealant and create voids. But yeah, so what I do is I put the GP in and then I just cut it and then I go and compact it. Now I do this so it's easier to put the other GPs in, but I always tend to put all the GPs in first before I do my down pack and my continuous wave compaction. Okay, because you'll find sometimes that, for example, let's say that these 2 canals are joining. If you just put this GP, let's say the mesiolingual one, and then you just down pack, you'll find that you have GP going into the other canal, and then you won't be able to put the other GP in to do the same thing. You'll just have to redo the preparation of the canal. So you'll be causing problems to yourself with no reason. So just put all the GPs in, and cut all of them, and then start with your down pack. Okay, you'll save yourself a lot of problems. Okay, So I'm doing this, I'm compacting it, and then I'm going to be doing the distal one, same thing, cutting, compacting, and then I'm going to be moving on to the down pack. So what I'm doing is it's just something that I do. Now, if I don't think that's right, then just drop a message in the comment section. I just put my plugger in, my heat plugger, and then I just move it around like that. I feel like it's compacting it a little bit better, and also I find that the GP sticks a bit better, and it cuts the GP much better, and it removes it all at one. Ironically, in this case, it didn't come out with the heat plugger. Jokes on me on this one. But yeah, he usually tends to work, and I've found that this works for me. So yeah, whatever works for you. So you just use the plugger to just plug it. Remember, this is very important. You're just pushing sealer and GP into those lateral canals, filling all the 3D anatomy. Okay. So after that, I'm not going to show you everything. I'm just going to be showing you how you go in with a heated GP. I fill the canal cup. I do tend to go into increments, like a few millimeters, and then press. It depends on how big the canal is and how much I have to fill. Okay, in this case, it wasn't much. So going like that, compacted, and then I'll repeat the same procedure to the other canals. Now I do fill both of the canals one go and then compact it. I don't suggest you do that. I do suggest going one by one. So you do the compaction a little bit. So you got more time because you have to hurry when you do it like that. Okay, just like that. All right. Yeah, that is all. Like always, if you got any tips, any suggestions, just drop them in the comment section below. And don't forget to like, subscribe, and hit the notification button. And I'll see you again next time. Thank you so much for watching. Take care.